Welcome and thanks for listening. This is Dr. Chad Rappaport from Northern New Jersey. Today I'd like to talk about and review avascular necrosis of the talus. This is not a representation of works that have been done or studied or investigated by myself, but rather a compendium of the current literature that's out there on this subject matter from journals like Foot and Ankle International, Techniques in Foot and Ankle Surgery, Foot and Ankle Orthopedics, the Journal of Foot and Ankle Surgery, etc., etc. In particular, I'd like to point out and give credit to Andrew Haskell, who is from the Palo Alto Medical Foundation in San Carlos, California. He authored a rather comprehensive review of avascular necrosis in foot and ankle clinics back in 2019. Much of what is within the confines of this presentation were borrowed from that particular article more than any other article in particular. So I want to thank him and give credit where credit's due. Avascular necrosis or osteonecrosis is frequently a debilitating and progressive condition triggered by trauma, steroid use, and other identified or perhaps non-identified risk factors. There's a wide spectrum of presentations and symptoms that can make diagnosing, working up, and treating these patients difficult. However, with that said, understanding the natural course is vital to prevent unnecessary invasive treatment in a patient that you would perhaps think would improve organically or naturally, or conservative treatment that is doomed to fail over the long haul. In particular, one of the perplexing scenarios associated with avascular necrosis, which we'll discuss, is how do you treat a patient with known avascular necrosis, but no collapse and minimal symptoms? First, let's talk a little bit about staging, which with regards to AVN is based on radiographs or tissue changes, but may not correlate with the patient's symptoms. The PCAT classification is the most widely accepted classification when discussing AVN, and it's gone through several iterations over the years as imaging modalities have improved and generally the understanding of AVN of the talus has improved. It comes in 5 flavors or stages, if you will. Stage 0 is the preclinical stage, where stages 1 and 2 are pre-radiographic and pre-collapse with positive X-ray changes noted in stage 2. Stage 3 is collapse with intact surrounding joints, and stage 4 is the emergence of or onset of osteoarthritis as a result of the AVN. The primary pathophysiology of avascular necrosis centers around or is characterized by massive bone death. And although infection, osteoarthritis, and osteochondritis dissecans may contain areas of necrosis, they should not be misconstrued to be the same as the pathological process of avascular necrosis. Radiographically, AVN presents with increased areas of bone sclerosis or regions of mixed lytic and sclerosis of the bone. It is most commonly encountered in the femoral head, although it can also be found in the more distal aspects of the femur and thus the knee. Of course, it occurs in the ankle and will be the focus of tonight's discussion and review. It is also encountered in the shoulder, elbow, and wrist. As the disease progresses, it ultimately may lead to some chondral collapse, creating the so-called crescent sign with associated joint destruction and arthritic changes. So let's now focus on the ankle itself and the talus more specifically. Of course, we're all familiar with the incidence of avascular necrosis in the talus following talar neck fractures. We're also familiar with the Hawkins sign, which is a radiographic finding of subchondral osteopenia caused by osteoclast overactivity. It's usually seen at 6 to 12 weeks after trauma, and again should not be mistaken for avascular necrosis. It is known to be 100% sensitive, but only about 60% specific. So the take home from that is the absence of a Hawkins sign does not guarantee the formation or development of avascular necrosis. And to illustrate this, Chen et al. Out of Foot and Ankle International in 2014 had a study where Hawkins sign was present in 50%, 30%, and 33% of grade 1, 2, and 3/4 talar neck fractures, wherein avascular necrosis developed in only 0, 10%, and 50% of those tali. So again, the absence of a Hawkins sign does not absolutely guarantee that avascular necrosis will set in. The slide here illustrates a nice depiction of Hawkins sign seen on plain radiographs of the ankle and segues into a brief discussion of imaging. X-rays, of course, are widely utilized and easily garnered, but MRI, CT, and nuclear medicine may supplement radiographs, particularly and specifically MRI, which can often show the location and the severity of the avascular necrosis more consistently and accurately than plain radiographs. And they should be considered in high-risk patients with whom you have a high clinical suspicion of AVN, or and in patients who have negative x-rays, of course, or in post-traumatic patients with a negative Hawkins sign. Now, going back to the FECAT classification, if you remember, stage 1 is pre-radiographic, and this occurs because initial cell death is not going to be seen, typically not seen on plain radiographs, but it can fortunately be seen on an MRI and is characterized by an initial sclerotic change seen at the margins of the developing lesion. And as this progresses, there becomes a high signal intensity at the inner border with decreased signal at the periphery or rim, which is often referred to as the double line sign, which is not honestly all that common in the ankle. It's more commonly found in radiographs of the femoral head and some of the other anatomic areas that we discussed before. An MRI will also show extension of the lesion on T2 images and circumscribed areas of decreased T1 and T2 signal. Here we can see these changes depicted quite nicely on MR images, of course a T2 on the left and T1 on the right. Avascular necrosis of the talus is relatively rare, although the true prevalence is not really known. It comprises 2% of all cases of symptomatic avascular necrosis, and when it does involve the talus, it's generally subdivided into two subfactions: AVN that was a direct result of trauma, and AVN with no clear-cut sign of initial trauma. And although the final cause of AVN is obviously an interruption to the bone with regards to the blood supply, the originating insult can be highly variable and depend on underlying medical conditions, associated risk factors, and or the patient's genetic predisposition. The leading cause of avascular necrosis of the talus is post-traumatic and most often associated with a displaced talar neck fracture. However, other foot and ankle traumas, even more minor ones, can cause avascular necrosis of the talus. The age, because trauma is the primary cause, can vary widely, as you might imagine. Men are more commonly affected by this than women, and as you might imagine, this is typically seen unilaterally. The risk of avascular necrosis, of course, increases with the severity of injury. We're all familiar with the Hawkins classifications and the reported incidences of avascular necrosis as the injury becomes more expansive and involves the subtalar joint, ankle joint, and the talonavicular joint. Not too long ago, it was thought that the more quickly one reduced a talar neck fracture, the lower the likelihood was that the patient would develop avascular necrosis, and to a large degree, these were deemed somewhat urgent surgically. The literature has largely refuted this over the past 10 or 20 years or so. We now know that the risk of AVN is more associated with pronounced displacement and soft tissue injury. And then, of course, is as a result of the blood supply being quite limited to the talus due to its proportion of articular cartilage with limited entry for perforators. In some cases of avascular necrosis of the talus, there is no traumatic history, and more often than not, these cases are caused by a variety of medications, alcohol use, or systemic illnesses, which are known risk factors for the development of avascular necrosis. The femoral head is the most commonly affected bone in non-traumatic AVN, and much of our understanding of AVN is based on study of this region. The pathogenesis of non-traumatic avascular necrosis is incompletely understood and likely multifactorial. The blood supply loss to the bone can stem from vascular occlusion via fat emboli, sickled red blood cells, or nitrogen bubbles known as Cason's disease, or the vascular structures may clot in a hypercoagulable state or become compressed from extraluminal pressure. Lupus, sickle cell, scleroderma, diabetes, MS, these are all medical comorbidities that seem to predispose patients to AVN. However, the most common pathway by which patients develop non-traumatic avascular necrosis is through the consumption of oral corticosteroids. This usually occurs, if it's going to occur, within the first 6 months after consumption. Interestingly, the use of statins seems to be protective in patients who also take oral steroids with regards to avoiding the development of avascular necrosis. With regards to timing of treatment, the FECAT classification really does provide a good overview of the current understanding about the natural history of AVN, wherein each progressive stage leads to the next, but timing of progression is variable, and not all will progress through all of these stages, and some may even recover or backtrack. The type and magnitude of vascular disruption determines the natural course of the disease, and therefore recognizing the exact moment of insult gives insight into the natural history, but can be very difficult. However, patients suffering trauma are typically treated from 6 weeks to 6 months or more, allowing a substantial window of time to allow a diagnosis. And generally speaking, if after 6 months there is no avascular necrosis, then it's very unlikely that it will appear. And this applies to both trauma or exposure to certain medical conditions or medicines. Lastly, the lesion size is also helpful, as these lesions rarely increase in size after the initial extent of damage becomes clear, and some pre-radiographic lesions may even decrease in size or go away or resolve, as some studies, MRI studies, have shown in the hip. In summary, with regards to timing of treatment, it is very difficult to pinpoint which patients will progress towards collapse and arthritis and which patients will experience a relatively extended period of stability, both clinically and radiographically. We do know that pain is probably not a reliable prognosticative factor, and joint-sparing procedures may minimize the risk of progression and can be appropriate when balanced with risk and morbidity of the procedure, which echoes the idea of treating each patient individually. You must keep in mind that bone integrity never returns after collapse, so timing of intervention is critical when contemplating joint-sparing procedures. Additionally, with the knowledge that joint destructive procedures have a much higher rate of complication when AVN is present already. So we'll take a couple of minutes to talk about each one of the stages. Stage 0, or the preclinical phase, non-traumatic, is difficult to characterize because patients typically present only when they have pain. It's likely that some people develop and then recover from avascular necrosis, given how many people are exposed to oral corticosteroids and alcohol, have medical comorbidities that predispose them to AVN but never present with pain or other signs or suggestions that they have AVN. On to stage 1, which are the pre-radiographic lesions. The history of these lesions likely depends on the size and the location of the lesion. Takatori in JBJS in 1993 published a study where they followed 32 femoral heads with MRI-confirmed AVN. These patients were asymptomatic, and over time they followed these patients, and smaller lesions away from the weight-bearing surface failed to progress, while most of the larger weight-bearing lesions collapsed. But of these, they collapsed at different times. Stage 2, or pre-collapse, defines patients with confirmed AVN who are symptomatic but fortunately have not experienced collapse yet. And the question is, do these patients progress without treatment? And the answer seems to be, for the most part, yes. And the key to preventing these patients from progressing seems to be protecting them from further trauma, which means non-weight bearing for the most part. There are several studies that have showed that increased periods of avoidance of trauma and non-weight bearing are superior to shorter periods of time with regards to non-weight bearing or patellar tendon bearing braces, etc. And the unofficial time frame seems to be around 9 months. Now, in many patients, this may be infeasible, and this, in addition to where the patient's lesions are, their medical comorbidities, and the risks versus rewards of intervention, should help or will help determine whether or not the way to go with that particular patient is simply keeping off of it for 9 months or more if they can, or doing something more aggressive before such time. So what else besides extended periods of protection and non-weight bearing can help prevent these patients from collapsing? Well, there's really no high-level evidence supporting this or backing this, but there is some literature that seems to show that bisphosphonates, and specifically Fosamax, coupled with calcium and vitamin D3, can help stave off collapse. Additionally, things like pulsed electromagnetic field bone stimulators, shockwave therapy, hyperbaric oxygen, and BMAC injection from the iliac crest have shown some promise with regards to preventing collapse, or at least extending the period of time that it takes for the bone to collapse. Stage 3 and Stage 4 represent post-collapse and arthritis of the affected joint. Again, these are FECAT Stage 3 and 4s. These are patients with no chance of macrostructural restoration, as you might imagine. Bony stability can be achieved or may be achieved, but usually with some degree of residual pain. And typically the measures, the invasive measures, include arthrodiastasis with adjunctive therapies such as PRP injection, stem cell injection, etc. Ankle arthrodesis or ankle replacement with or without total tali, which is something that I think will become more commonplace as the technology with 3D printing improves over time. So in summary, avascular necrosis of the talus can develop after a variety of traumatic or non-traumatic events that ultimately interrupt the bone's blood supply. The extent of the involvement and the risk and degree of progression is likely to be determined at the initial time of injury or exposure. Conservative measures such as extended periods of non-weight bearing, in addition to surgical interventions, may ultimately prove to alter the natural progression and the history of AVN. But when collapse occurs, joint-sacrificing procedures such as fusion may be required to alleviate the patient's symptoms. Thank you.